professionals have come to the fore to indicate that they're still looking for employment in the public health sector after completing their internship and also community service. I wish to state upfront that ourselves as the department and as part of this government, we really would wish a situation where all graduates and who have completed all these statutory requirements of internship and communities can get immediate employment in the public health sector. But of course, as I'll indicate, we is a number of challenges in that regard, but opportunities are also there. We would have wished that it's that seamless because of the major role which your health professionals, not only doctors, but the entire health professionals, improving the quality of life of our people. But also to emphasize that we're not only looking for the recent graduates, but also those who have experience, who have been in the service, can be deployed in various parts of the country where their skills are quite highly, required, but also to help also the young ones who are coming in with their experience. We also want to emphasize the fact that health services are provided by health team. Doctors are very, very important. They are because of their extensive training, as you would know that amongst the health professions, the medical doctors are the ones who take quite a long time to be trained, quite extensive. But they work within a team of various other health professionals, including physiotherapists, nurses, pharmacists, and so on. So the issue of doctors who wish to stay in the public service employment is indeed a concern for us, and sure those who are affected and from the community as well, from society, that we are doing everything possible, working with our colleagues in the provincial health departments who are the immediate employers in this regard. We are working around the clock with them and working with our colleagues in the finance, both national and provincial, to make sure that we can have more funded vacant posts, especially in the health facilities which are underserved. So those are the priority areas. But again, just to recap in terms of how our system functions, all graduates, in as far as doctors are concerned, all graduates from medical schools to first do a 2-year internship in designated health facilities. Those facilities are accredited and designated by the Health Professions Council. And then once they have completed the 2-year internship, they are now allocated in for community service. And the hospitals which are designated for community service, slightly different from the internship, because it's regarded as full training, practical skills training. That's why it's designated by the Health Professions Council. The community service, the purpose of introducing community service a number of years ago was again to improve clinical skills, but also providing service in the underserved area. So that's why you will find that the facilities where this happens will be not the same. There will be some overlap here and there, but quite a number of areas you'll find that, for instance, your teaching hospitals, your central hospitals are eligible to train interns, but they are out of bounds in terms of community service because they are not considered as underserved. So that's what the purpose of community service. So it will be rural areas, township hospitals, and also other marginalized areas. And in terms of, just to clarify, because sometimes I think all of us have had to answer questions sometimes because it's a specialized area. People get confused and they think that this issue of the shortage of funded posts affects also the training. So I want to say, quite unequivocally here that in as far as internship and community services, which we regard as a statutory obligation by the state, we don't have graduates fresh from medical school who are stranded in terms of getting internship. Those posts are funded and everybody who's eligible has been allocated. Community service, the same thing, equally, those are all allocated. The question people may ask, why are these ones protected and how do we manage? So a few years ago, we discussed with the colleagues in the finance, the Ministry of Finance, the National Treasury Department, to have an allocation in the form of what you call conditional grant for training, which it previously was more for specialists. But then we entered into an agreement where the conditional grant for training was also increased to include internship and community service as part of the training. So we do allocate to provinces. That amount is protected, it's ring-fenced specifically because that we consider as part of provinces are also do add, because this category of doctors also provide very valuable service at the facilities where they're working. So that is why we're able, through that arrangement with our colleagues in finance, we're able to protect that category. So we do appreciate the fact that there are many medical officers. Sorry, before I go to that, just to explain, therefore, that once a doctor has finished community service, they are now registered under a category in the Health Professions Council, which is called Medical Officer for Independent Practice. So from your professional apprenticeship, you are now regarded as fully capable. That's why you are regarded as also independent practice. So you're free to you can work on your own. You've got a full registration without supervision, whether it's in the public health or even in your own private facility, including in partnership with other colleagues. So we do appreciate the fact that there are many medical officers who are now registered, but who would want to stay in the public service. That's very important. We do appreciate that. But due to the fact that unlike internship and community services, which are statutory requirements and are subject to placement in the health department. So when you see Dr. Mahlati there in the white shirt, the branch which he heads, he supervises other colleagues who run the system of placement for interns and community service. We do it nationally, working with all the medical schools. They give us the data before the graduates finish the end of the year exams, and those who are in internship, we've got a system which then is coordinated nationally. Now, because of the fact that when the doctors finish community service, there is no more a placement. There is no more a system where people then have to be placed. They are eligible for independent practice. So they have individual choices. Some will decide that they want to specialize. Others will decide that they want to go into private practice. Others will decide that they want to stay in the public service. So that's why we say we do appreciate that. But because of the fact that it's not organized in the same way as the statutory obligation, we don't actually have data, because people, once they exit the community service, they are free. So they are free to, as I said, do whatever. I mean, we know colleagues also who some just go and do research, join Medical Research Council or other research institutions, and don't proceed with the clinical training. So that's why it's only later, as people start working somewhere second week, third week of January, that we start to get information in terms of the number of qualified medical officers who have completed community service, who wish to stay in the public service, where they meet certain challenges in terms of not finding posts. And again, to emphasize here that because you are fully qualified and registered now, it's even up to you to decide, do I work in Limpopo? Where am I looking for a post? Is it in Mpumalanga? Is it maybe because I've got a family or a boyfriend or a girlfriend somewhere and I want to go there? So it's all, so that's why it becomes difficult to know who's looking for what. So that's why then it is only later that, so in the medical profession, we have the South African Medical Association, which is a professional association, which also then have a trade union. Well, when Dr. Mahlati was still there in that association, the two used to be together, but somewhere down the line they separated. So you've got an association on the one hand, and then you've got the trade union, but they are all still medical association. The other one is medical association, the other one is medical association, trade union. So we get information quite often over and above individuals who inquire. We then got, the same thing happened last year. Also this year, about second week of January, we then get information from the association and also from trade union to say, we've got a number of members who have been looking for vacant posts, want to apply, and they're not finding. And then we communicate with them, and they give us what information they have. About maybe 2-3 weeks ago, we got the complaint from the trade unions for a start, and then the medical association also approached us. And then the unit under Dr. Mahlati then communicates with them to get the names so that we can compare and look. So they did that. We got a number of, the trade union gave us just over 825 names. And then the team then had to check through, look at the history, because the names, ID, registration with the Health Professions Council. And they then arrived at the number of 694 who they could confirm had recently qualified from the community service. And then the association also gave us a lesser number. I think initially the association gave us just over 250 or so names. And then later on, they upgraded it to just over another 100, about 350 more names. So you can see also, because not everybody who's in the association is in the union, and those who are in the union, it looks like it's the majority, because they gave us more names. Now, we've then been working with them to say we must identify the opportunities. As I've explained earlier on, that unlike internship and community service, where we aggregate all the posts nationally, and that team, Health Choice, I think up to 5, and then they allocate, they tell you. Now this one, because it's a free situation where these are fully qualified people, we then have to check with provinces where there are vacancies, because provinces have to advertise the post as is required by the Public Service Act. So we then work with them to identify where there are those vacancies, and then we share that information with this organization, so that the doctors who are the members and those who are may not be their members, but who maybe directly inquire with us, or we're able to direct them to those provinces, to the posts which have been advertised. Of course, we have to clean up the information, because from the just over 825, which the trade union had submitted, some of those we found that they had not yet completed. They were still busy with 2 months or 3 months or more of the community service. Some start late, so we had to look at that. I must say, while talking about this, to say that the provinces do face a lot of challenges in terms of budgetary constraints. There is a lot of pressure on the budgets because, as you know, cost of employment increases, they get under more and more pressure. And of course, just to also come to another pressure over the last year, which added to the pressure on the salary bill, was the agreement between government and such that even before these increases, they were already approaching 70% of their annual budgets being for salaries. So the risk in terms of this is that it crashed in terms of medicines, in terms of linen, in terms of many other, including clinical equipment like X-rays, ultrasounds, CT scans, and all those sophisticated machines which are required, all the kind of the things which you need just to run the service become quite crowded. So those are the challenges which we face. But we are thankful, nevertheless, that when there was a salary increase of 7.5%, even though initially Minister of Finance and Treasury had said that all departments must find the money to pay this increase within their budgets. Later on, there was a consideration to cushion a bit on health and education and some of, I think, also on the law enforcement side, the police and justice. We received, I think, just around 65% of the additional cost of 7.5% was allocated to our sector. So it was a bit of a cushion, but it means, again, still that we still need to find within our budgets the remaining 35% of that cost. Now, I can just also indicate that the health sector is quite a costly area of work. There's been improvement of benefits over time. Some of those dating back, it was a good initiative, I think about 15 years ago, around 2008, 9, 10, when there were discussions and agreements to introduce occupation-specific dispensation. It's not only for health workers, but also for other professions. Now, and then, of course, in the medical side, we also have overtime, which is almost like included as a benefit. Generally, all doctors in hospitals have a basic salary, but also the overtime is almost taken as part and parcel, because it's assumed that generally all doctors, full-time in their hospital, will have to do the night and calls. So now those benefits do push the salary bill quite high, and one of the anomalies in this regard is, for instance, I know that this will not be in the public domain. Entry level community service doctor, when you include the salary and the overtime, the total cost to the government on community service doctor is about 1.2 million. And then those who work in areas which are designated as rural, they will have another about just over 100,000 addition for rural allowance. So that will be about 1.3 million per annum for an entry level. And then once they qualify from the ComServe, when they must come in as a full, what is called a grade 1 medical officer, those costs rise to, without rural allowance, it will be about 1.4 million. It goes to, in the rural, those designated as rural, it will go up to 1.5 million for entry level after community service medical officer. Of course, so this is quite when you have a situation like this, then and the other anomaly is that ordinarily in the public service, those levels of salary are also part and parcel of what is called management. In the public service, you've got what is called, there are 16 levels. Level 1 up to 12 is below management, and then from 13 to 16 it's regarded as management. So when you hear that there's an agreement on a particular percentage of salary increase, it affects those below management from level 1 to 12. But the medical side, even those who are on package of up to 2 million, 3 million, I mean, the US chief specialists can go up to 3 million rand per annum. But they are still categorized as not because they are clinical. So all this increases, whether it's 4%, 5%, like even this 7.5%, also it's something which becomes a benefit and then pushes the pressure on the fiscus in terms of the departments and the hospitals quite a lot. But nevertheless, one want to also emphasize the fact that so this is not something which happened overnight. The pressure on the fiscal, that currently with all the pressure, all of you are aware of the controversy in the way around the letter which was issued by the outgone acting DG for Treasury towards the end of his, in fact, on the last day of his tenure, issued the letter which called for well, other people want to call it austerity, but the real term is cost containment. So because of the fact that the Treasury felt that the fiscus was starting to heat up too much. Notwithstanding that, we want to also just indicate that there has been continuous increase in the uptake in the public service. The production of, especially because we're talking about doctors here, there's been a continuous improvement in the qualification of doctors and their employment in the public service. Just to give you just two examples, in terms of internship, in 2018, at the end of 2018, there were 1,400 interns, 1,470 for accuracy, medical interns. But at the end of 2023, or at the beginning, let me say at the beginning of 2023, there were 2,365 interns who started. So in 2018, January, there were 1,470. And in January of 2023, there were 2,365. So almost 1,000, just under 1,000 more interns in that period, not even 10 years, from 2018 to 2023. This year, those who started their internship in January is 2,210. So you can see the level of growth from 1,470 to 2,210 this year. In the community service category, there were 1,340 in 2020. As we speak now, those who've started their community service is 2,101. So again, you can see from there just over 700 increase in the cohort of new doctors who have come into the service as either as interns or community service. So of course, we would have wished that even as they complete their training, there will be a lot more. It will be good if they would be spoiled for choice, but of course, the pressure on the fiscus is there, and which makes it difficult. We also want to emphasize again that we're not only looking at the job opportunities for medical doctors. As I said, health team is a collective team. We're looking at opportunities for nurses, physiotherapists, oral hygienists, dentists, and all other health professionals. So we as I've said, we are working with the departments who are also engaging their own provincial treasuries in terms of making sure that there are opportunities. So all the provinces have identified posts which that already have been advertised or indicated to us that in the next few months they will be able to advertise. So as we speak now, across provinces, we have been able to find just 239 posts which are already on, out there for the uptake. Gauteng has got quite a number of those. Eastern Cape has got quite a number. I think Mpumalanga and Eastern Cape, Free State. We do have a challenge in a province like Limpopo, where they have not been able to release posts because there is a court matter between the Limpopo Department of Health and the SAMA Trade Union. And the reason for that, Limpopo tried to some more opportunities by reorganizing the overtime component to try and structure it such that it can be spread out and spread to more people, have the basic salary, and then break down so that they can then have more people employed. But then the trade union was not happy that as far as I understand it, well, in terms of overtime, I mean, when you get employed, what is guaranteed is your basic salary. The overtime is supposed to be on the basis of need. It can be reviewed from time to time. But the trade union is challenging the fact that the province wants to review the overtime so that it can spread the money and be able to employ more people. So as a result of that, when they wanted to advertise, their provincial treasury advised them not to advertise because the matter is still in court. And if whichever way, if they advertise on the basis of how they want to restructure, then they will be taken as going against a matter which is in court. We have also, the provinces have also indicated that while these 239 are already, we do have the adverts for some of this, and we've already given us copies. There's also, they are looking at possible just under 400 more posts, which will be available in the next few months as they reorganize their finances, and as some people, will leave for other greener pastures or whatever. So they've indicated a number of about 375. So when you look at these numbers, they actually suggest that the 692 which have been confirmed between our department and SAMATU, in due course, about 239 those could be employed in the next once the vacancies are filled, and the other 375 down the line in the next 4 months or so, when the provinces are able to release more vacant posts. But again, we just want to emphasize the fact that while we would wish that this would be seamless, we must take into consideration that once you are out of the regulated training and community service, you are almost like any other profession, which when you've completed all your training, you're going to depend on where opportunities are. I think where maybe the medical profession slightly have been different over the years when we are not training as many doctors as we're training now. I mean, at some stage, we're training less than half of the numbers, as I've indicated, just in 2018. And even by 2018, we had already ramped up training. I mean, there were times when, I wouldn't even talk about, the ancient days of myself, Dr. Mahlati, and a little bit younger Buthelezi, but myself, Mahlati, and Dlomo, who are a little bit of ancestors. I mean, when we would have qualified, there would have been possibly 600 doctors in the whole country in a year, 900 at the most, below 1,000. And now we're talking about over 2004, 2005 cumulatively. So during those times when there was a, much limited qualification of medical people, it would, the vacant posts would have been quite, easy to access. You still had to apply because it was never, it's still not based on just the allocation because you have passed your training area. But because there was a much more limited numbers of doctors who qualified, they would have been much easier to find even where you trained as an intern, because during our time, of course, there was no ComServe. But even earlier on when the community service started, even the reason why we introduced community service many years ago was to alleviate the pressure on the disadvantaged hospitals. So in as far as that is concerned, the multi-pronged, we are working immediately with provinces, identifying vacancies so that we can then advise colleagues in the unions and the associations and those who come approach us either nationally or provincially directly to say, there are the vacancies, you have to apply. I mean, there is no automatic placement to say you because in any way, since you are now under category of independent practice, you have a choice even as to which whether you want to go into a province or whatever, as I've said, different institutions. So you have to indicate interest and put in an application, and they have to process it. And then after that, after undergoing the necessary processes, you will be appointed. Just the last brief matter which we wanted to just to update. I'm sure many of you would be aware that some few weeks ago we did announce that there were some cholera cases which have been identified in our country. Earlier on the 16th, I think it was, on the 15th of January, I remember, I got a call from the MEC of Limpopo indicating there were 2 cases of cholera at the time. And then a few days later, Gauteng also identified the case at the Helen Joseph Hospital. Subsequent to that, it was quiet. Those recovered, and there were no further cases. But last week, Limpopo identified 2 siblings in an area called Blowback municipality. These are siblings who had diarrhea symptoms and were confirmed to be having diarrhea. And there were other people in the surrounding who also had presentation of diarrhea. So we are working with the province to identify, to follow up, trace the contacts in the families and also in the surrounding, and also with the environmental health practitioners, so that we can be able to find the source in that local municipality of Blowback. Otherwise, the other earlier cases, the other 3, both in Limpopo and in Gauteng, were what we call imported cases, all 3 from people who were in Zimbabwe and came across South Africa. Just to conclude on that matter, to say 2 days on Friday, we had a meeting with the SADC. SADC Secretariat convened a meeting. It started the previous Saturday, where Deputy Minister Dlong represented us, where SADC ministers of health were discussing this outbreak, because the major outbreak, we don't really have an outbreak in South Africa at the current moment. It's isolated, mainly imported cases, except these 2 endemic cases in Blowback. So we spoke to the WHO country office to help us to coordinate SADC. So they spoke to Africa Center for Disease Control, and together with the Africa region of WHO. So they called the ministers of health to discuss strategies of working together across the borders and so on. So following that meeting of health ministers on Friday, there was a meeting of heads of state to get a report from the health ministers. So I was delegated together with Minister Pando to attend the heads of state meeting. So the heads of state, we agreed on there was a communique or an agreement kind of statement, which committed all of us in the Southern African region to share information, to share data, to share even the testing, whatever screening we do at the borders, and make sure that we work together. The countries which are facing real endemic like Zimbabwe, we're also working with them to access cholera vaccines, because the cholera vaccine, according to WHO, systems, you only use the cholera vaccine when you have a serious outbreak. So Zimbabwe having that, they are eligible to be assisted for vaccine. And of course, Zambia is also affected, Malawi. We don't really have any reason for any panic. Let me stop there, Mr. Mhar.
Thank you very much, Honorable Minister. Now we can take questions. I'm not sure if we have questions from visual platforms. Yeah, we will start internal visual platforms. Do we have? Okay. Yeah, let's start with the questions from the floor. Just introduce yourself, your name, and the media house, and the questions.
Good afternoon, everyone. My name is Teresa from News 24.
The microphone is failing you. You can try the next. The Yeah, go talk closer to the microphone and.
there was a number of junior doctors who were bursary beneficiaries from the department, and they were only told in December that they're being released from their bursary. What does that mean? Does it mean that they will no longer have to pay the money that they owe the department, or what does it mean? And how many of the students of those doctors are affected?
Which province specifically where these students come from? Or are you talking generally?
Generally, yeah.
Okay.
For the most part, it sounds like government doesn't have the money basically to hire as many doctors as it would like. So would you constitute this as a crisis? You do indicate that you will be advertising some posts. There are some posts that are already out. In essence, why can this process not begin at that internship stage? Why is it that government cannot get an indication from those that are about to leave that internship process on whether or not they want to stay in the public service or whether they're going to go independent? Lastly, due to the fiscal constraints, then, would you agree that it seems that capable doctors are being pushed out of public service and being forced to go independent because government doesn't have money, or it says it doesn't have money?
Okay. Hi, please.
One question from Alexa Network. We have noticed that there is a very high number of medical negligence claims in various provinces. Yet there is not enough doctors. Please provide a comment on this. Can the money that is used to pay medical negligence claims not be used to pay more posts for doctors and subsequently reduce medical negligence claims? That's Alisa from Redford.
Okay, we'll respond to these questions. If the follow-up questions, we'll take them.
Well, thanks very much for the questions. Usually, in terms of bursaries, when we talk about somebody being released from bursary obligations, it would mean that it was a government bursary, because usually if it was a scholarship from a private funder, there would usually be no obligations. So usually from a government-funded bursary, usually it will be provinces which would have funded, and then the contract for that bursary would be that when you finish, you're going to serve for the equivalent number of years. Now, it has happened, I know, from different provinces, not starting now, it's happened even a few years ago, where, so the contract is on both sides. It's on the bursary holder, but it's also on the funder. The bursary holder is obliged to serve, the funder is obliged to provide a post at the end and offer a vacancy. So it has happened where provinces, when they evaluate their financial situation, come to the conclusion that at the time, because when you now talk about obligations, and including that of a bursary holder, you can't say, I don't have a funded post now, I may have it in 2 months, because you are obliged, once that person finishes the training, the internship and the community service, which are funded through a nationally supported program, then you are obliged as a funder to immediately provide that vacancy. So if you're not able, because of challenges of funding at the time, even if you may have a vacancy in 2 months or 3 months, that doesn't work. So you have to let that particular bursary holder know that they are free. You have to release them, because then if there is, because they indicate that they want to stay, they want to fulfill their obligations, it's it's you as the funder who is not able to provide the opportunity at the time. So it's a breach of contract. So whoever is the one who breached the contract must then let go. And even if you're going to have a vacancy in a month or 2 months, you've broken your contract. So that's why, because of the law of contract, so the implications for that, even in a month or two, when that provincial health department does have a vacancy, they can't go back, as it has happened. They can't go back to the same person who they'd funded to say, we didn't have in January, now in February or March, we've got a vacancy. They can make that opportunity available, not on contract, on the basis that there's a contract, because they've broken the contract. So that's basically the implication. That person is free to go and, if they are already employed somewhere by the time they do have a funded post, then it means that that person is no more obliged to come back to serve in that particular contractual agreement. Well, if I think we've said that in the most ideal situation, we would have wished, notwithstanding, the growth in the human resources especially for medical officers over time, we would have various pressures, the demand for services, health, and even at the district and even specialist hospital level. Our preference would have been to have adequate financial resources to support our provincial health departments, as we do with internship and community services, so that they would be able to cater for everybody who comes out of a fairly extensive, good training. I mean, South African medical schools are well recognized all over the world as having good training. So we would have preferred that we are able to retain everybody who wishes to stay in the public service to stay there. But it is a matter of fact that as things stand at this stage, our colleagues in the provinces who are the employers are not in a position to do so, and we are working with them to free some resources and also look at additional funding. I mean, we are in a continuous discussion with our colleagues at the finance to see whether they could be able to come forward with more additional funding. So that we can't debate about the fact that we don't have adequate financial resources at this stage. Now, you asked the question as to as Linda indication, why don't we indicate at the end of the internship? As I've indicated, because of the fact that at the end of the obligatory period, which is the training, the internship, and the community service, I mean, there could be a possibility where vacancies which are expected would actually be released early. And in fact, 200, when we looked at I think 4 provinces, they were quite helpful. The 239 posts which were released by a number of provinces, they were actually advertised in October. So it was not enough, because out of the number of people who, as we know now, who wish to stay just under 700, there were 239 posts, but at least, so I think we're not too far if more provinces are able to identify vacancies earlier and in the same as these ones which advertised in October. Then those who, I think it's just the process of finally processing the applications, even for those. The reason why they are not yet filled up to now as we speak is because maybe the process, they probably advertised for, I don't know, 4 or 5 weeks, and then process the applications and all that. So the process can be improved so that people know much earlier as they go towards December when they complete, and if it's all already in the public domain as to where opportunities are, the people could be able to apply. But again, it's a very dynamic environment, because some of the people who are in full-time employment will only indicate, I think in the public service, you are required to serve 1 month notice. So you may know those which are already vacant by October, but they are, because the obligation is a 1 month notice. Some people who have plans for January to go somewhere, they may only indicate the notice that they won't be coming back, maybe somewhere at the beginning of December, because they are obliged only for 30 days notice. So it's again, because unlike internship and community service, which is a regulated environment, this is a very unregulated area. We can't appeal to not nearly said comrades, but to colleagues. Just come from voter registration and mobilization, so I still have a lot of comrades in my head. To the colleagues in the provinces, to make sure that where it's possible, the release of the vacancies which are available should happen earlier. The fact that there's a paradox that on the one hand, we're dealing with medical legal claims where amounts of monies are being paid out for claims, while at the same time we're unable to employ people who would help to reduce this. It's indeed true. We are doing everything possible to reduce on the medical legal claims, because this drains a lot of scarce funds, which otherwise should be used to improve, not only in terms of human resources, equipment, medicines, and other life-saving, commodities. So it's a matter which we are working around the clock, and there is some progress. It's not happening as speedily as it should, but clearly you're correct that the person who online asked the question is correct that this would free a lot of resources. I mean, in one particular province, which I will not go into details now, in one financial year, 900 million was paid for medical legal claims in one financial year. I mean, that would have absorbed all these 692 medical officers, just that amount. It would have been enough to absorb all the 692 medical officers. So the questioner is correct that it's one area which, if we're also able to prevail on it, even though it's not spread throughout the country, but there are particular provinces which are really having a major suffering quite a lot in as far as the payments to claims for medical litigation. Thank you very much, Costa.
Thank you, Honorable Minister. Now we can take the last round of questions. Clarity follow up. I've got two questions from.
You know why your microphone is not? There's a microphone which is left on at the top there. Once you've got.
So can you put that microphone off?
Yeah, that's why the other ones will do.
Hello. Oh, yeah. Thanks. We've got two questions from Business Day. Our good colleague Tamakan is asking. Let me check. Tamakan from Business Day. Questions are as follows. Cabinet has recently approved a new loan scheme for students from missing middle without a long-term strategy for raising the funds. Given that the Treasury will have to find the funds to fulfill this promise, there will be less money for frontline services such as health workers. How do you justify funding the students at the expense of patients?
Missing middle.
Yes.
So just read the question again.
The question, let me do like this. Let me, so that we can, even though the question sounds like it's more on treasury than us, but yeah, I send you via WhatsApp. I send you via, those are very long questions so that you can summarize it. The second one, what advice are you giving to provincial health departments to minimize the impact on service delivery on the recent budget cuts and even deeper cuts anticipated over the medium term? Are you, for example, advising the departments to prioritize which posts based on the projected further budget cuts? Is the national department or minister advising the provincial departments which posts to prioritize when they advertise?
Maybe let's just go to that first one, Tamarkan.
Okay, maybe while I'm not sure if any follow-up questions on the floor. Celine? Yes.
I don't think my question was answered about whether this constitutes a crisis, these budgetary constraints, and whether or not these budgetary constraints are pushing doctors that want to stay in the public sector out.
Okay. You got the question, Minister?
For the one from Tamarkan.
Tamarkan and also the follow-up, Celine? Okay.
Well, I can see that you want to insist on crisis or no crisis. You know, that is really more of a choice of description. What I'm saying is that we are not in a best of situation. We would have preferred a situation where we're able to provide opportunities for everybody who wants to serve in the public service. To call that a crisis, it really, depends on your definition of what constitutes a crisis. I would say, it's like every time I go to Parliament, the opposition say service is collapsing or collapsed or collapsing. And that would have been over even before my time, whenever we would be in Parliament. Now, you may ask yourself, if, let's say, from 10 years ago, it was collapsing, where is it now? You know, because we would argue that it's under stress. There's a stress. We're working under difficult circumstances. But the public health system is still holding on. If you go to most, if not all, our health facilities, you will find people receiving services. Of course, what will hit the front pages will be the occasions where something goes wrong. But on an average day, out of 100 people who go to health facilities, they may have waited for a long time, but they do receive the service. And we also do get compliments, which of course doesn't hit the front pages. So despite the pressure, we would have wished for a much better situation. So I'll leave that to your own judgment as to whether, as for me, I would say I would accept the fact that we're not in the best of circumstances. We would have preferred better. But in terms of whether that, then the fact that we are not able to perform at the best of what is available, because those well-trained medical officers will add impetus to improvement right from the primary health up to the highest level, because also train as specialists. And we're also addressing that issue in terms of continue to train the good specialists who South Africa is also well known for in all fields. The South African. So whether therefore, of course, when people would wish to stay in the public service and there are no opportunities because they are well trained, some will opt to stay in the country and join, because of the fact that they are well equipped to can even run their own practices. We hope that majority will do so and not leave the country, because our plans going forward, what we envisage, especially at the primary health level, it's more role of general practitioners. We talk about the medical side. We want to create opportunities for general practitioners in the community to also provide services, expand the services in their own rooms on an agreement with the state. That's what the NHI basically is looking at. And or else there are already some who provide service, not only in their rooms, but also in our clinics. There are many GPs who also work certain hours in our clinics. So we hope that majority will take that route, join others who are already running, communities practice in their GPs, and then give some hours also to the public service. So we just hope that they definitely don't opt for offshore, but remain in the country. We will understand even for those who go out, and especially if they go and train more, with the understanding that they will come back to the country at some stage. So it's not really. But let me also just add to say, and I think it deals also with Tamarkan's question. While it is good for any country to provide opportunities for the people it trains at the expense of their taxpayer, but even in a situation where at the end you may not be able to employ all the people who you have trained, can never be a waste. And therefore, dealing with the question she is raising, we just hope that giving these young people opportunities for skills through this gap, which Minister of Higher Education is now addressing, of the missing middle. But remember also that when you talk about the missing middle, I'm not sure where the medical officers fit, but definitely the teachers, the nurses, and other public servants. As I've indicated, the medical officers' salary is a little bit on the upward, especially when you add your commuted overtime, as you are indicating that. I mean, for a first year in 10, the total package without rural allowance is just over 900,000 when you include overtime, which is usually part and parcel, And then once they qualify ComServe, it's 1.2 million. Once you go into medical officer grade 1, with all the allowances, is 1.5 million. So I doubt if those qualify to be the middle people. But the other healthcare professionals generally would be within the middle. So I would hope that what Tamar is suggesting, that because this is not fully funded, some of the money which will be used will come from our services. We hope that will not be the case. From what the minister has presented, if I'm not mistaken, they are also working with the banks, with the private funders, to try and raise more money for the because I speak under correction, but if I'm not mistaken, that funding for the missing middle is not going to be a full grant, unlike the ordinary NSFAS, which is currently a grant. I think the missing middle one, there is an element of a loan, so there will be some recovery. But I speak, and I think if I remember well, that's what the dispensation. And I want to argue that those graduates, in the same way as while we regret the fact that we can't immediately guarantee every medical graduate a medical officer posts after ComServe. It is a worthwhile investment. They can use that, training, especially with having finished internship, ComServe. They can be able to even establish their own practice, but also if they want to explore elsewhere, they are quite well empowered. It can't be a waste for the country, and people go and come around. I mean, we know of many people who left the country and are back and providing service. So it's not the most ideal, but so I leave it to Slindelo as to what the characterization of crisis. My apology that I'm not going to oblige. Thank you.
Thank you, Honorable Minister and colleagues, for joining us. Before I officially declare this meeting, can I check if there's any last clarity-seeking question? Comment? Okay. On that note, let me take this opportunity to thank you for making time to join us on this media briefing. And feel free at any time if you have got other follow-up questions outside the briefing. We've got the officials here. Dr. Matlatia is always there for you. DG, Deputy Minister, even Minister, when he's available, will deal with other issues. So on that note, let me officially declare this media briefing agenda until we meet again next time. Thank you.